شكرا جزيلا لنا
Will you let me know when to start?
Yes, we will introduce you.
Oh, you will introduce me. Okay. Thank you.
So we start our first Siemens symposium. Our speaker is Mr. Ernest Moore. He's a program specialist in chemistry at Siemens engineers. He's going to give us a talk about COVID-19.
Thank you. Good morning, ladies and gentlemen, and it's good to present to you today face to face rather than virtually, which we've been doing for quite some time since the pandemic started. So this morning, I'm going to speak to you about Siemens Healthineers COVID-19 solutions, and also how we are assisting healthcare providers with support to the pandemic. So firstly, I'm going to begin with some defining terms, the basic terms. SARS-CoV-2, which is severe acute respiratory symptom coronavirus 2, and this is the virus that causes COVID-19. COVID-19, which stands for Coronavirus Disease 2019, is the disease resulting from the infection with the novel coronavirus. So at Siemens Healthineers, we are aware of the urgency and the complexity of the current situation, and we are working very hard to provide the best possible support to healthcare providers at each stage of the COVID-19 patient care. So, and that includes from the diagnosis to the prognosis, therapy, and eventually the follow-up. And this includes for diagnostics and imaging. So the COVID-19 pandemic has placed immense pressure on the clinical laboratories on the front line of diagnosing SARS-CoV-2 infections. So from July 2020 to January 2021, the test capacity has increased by 500%. And this has significantly outpaced many labs' capacity for PCR and rapid antigen testing. The supply and the installation constraints of instruments and materials needed to complete sample collection and testing has also contributed to testing challenges. And manufacturers continue to try to ramp up capacity to meet this demand. Although molecular testing is the gold standard, it has its issues when it comes to throughput. I mean, 25 to up to 95 tests per hour. And therefore, this causes some strains to the laboratory as well. When the pandemic first started, there were a lot of diagnostic tests available, and there were accuracy issues in regard to the quality of the results. And this caused some sort of lowered the trust of the public towards these diagnostic tests. We do know that testing is the tool in the diagnosis of monitoring COVID-19. And here we see at the different time frames where the appropriate tests can be done to either diagnose or to monitor patients with the COVID-19. As you know, the molecular testing can detect the virus at the very early stages of the pandemic. The antigen testing depends on the viral load. And this has a very short period, most probably from 1 to 3 days post a pre-symptom onset to up to 10 days post-symptom onset. And if you look at your antibody testing, you will know that the IgM and the IgG, they both are produced simultaneously. And this is not common with the other disease states, where the IgM is produced first and the IgG is produced at a later stage. So this is very unique to this virus. So we have a large portfolio ranging from detection to management and monitoring, starting off with satellite testing with our point of care rapid antigen test. And I will go through each one individually more in detail. If we move over to the large scale testing and diagnosis, we also have available the high throughput lab antigen testing. And then we have the gold standard, which is the molecular testing as well. And if we move over to patient management and monitoring, we have 2 antibody tests, serology antibody tests, which include the total antibody assay and also the IgG assay. And then also moving over to the point of care, we have the antibody testing available as well. If we focus on the point of care rapid antigen testing, it's available in both the anterior nasal swab and the nasopharyngeal swab as well. And both have a very high sensitivity of up to 97.3% and also a very high specificity of 100%. And with the point of care rapid antigen testing, you can receive your result in 15 minutes. So the rapid antigen testing can be used to test individuals with or without COVID-19 symptoms, just to monitor the patient population. The patients can self-collect their nasal specimens under the supervision of healthcare professionals. There is no laboratory equipment or personnel that is required. It's also a very scalable testing for the population health management as well. And then we also have the self-testing kits, but this is only available, currently available in Germany and Austria. If we move over to the large-scale antigen testing, this assay is available in both the anterior nasal swab and the nasopharyngeal swab as well. And also it has a very high sensitivity and specificity, a sensitivity of 98% and a specificity of 100%. If we look at running it on our Telica IM system, which has a throughput of up to 440 specimens per hour, we can receive our first result within 26 minutes. So this assay is targeted to high testing capacity so that we can maximize our resources. And we also have a pre-treatment which will protect the laboratory staff, which will inactivate the virus prior to the lab personnel running the specimen onto the instrument. And this is a very short incubation period for inactivating the virus, which is approximately plus to minus 10 minutes. It has a very high accurate detection with a very low viral load, and I'll speak about this a bit later on one of my slides. And this is better capability than when it comes comparing to other serology antigen testing as well. We're the only manufacturer that uses 5 monoclonal antibodies to maximize the variant detection capability. We have just conducted tests with the Brazilian, the South African, and the Californian variants, and our assay detected these variants without any issues. We will be publishing that document very soon as well. It's also very quick to detect the positive cases, and it will allow timely protective measures and appropriate follow-up. And also we have more than 9,000 analyzers worldwide that can utilize this assay on their instruments. So the World Health Organization and the CDC recommendations in the US has identified the potential applications of these antigen testing to fight the COVID-19 by expanding access to faster screening for individuals. So if you look at in which scenarios we can use the antigen testing, for example, in situations where specialized laboratory equipment or laboratory personnel are unavailable to quickly respond to the COVID-19 outbreaks. Now, this refers to the remote areas where it's very difficult to set up these pop-up laboratories and then have the experienced laboratory personnel available to conduct these tests. So in this scenario, we can use the rapid antigen point of care test to identify positive cases. It can also be used in outbreak investigations in closed or semi-closed settings or instances of widespread community transmission. So we're looking at scenarios where in schools, universities, healthcare home facilities, even at workplaces as well. And I've just heard from our frequent global COVID-19 calls that France and Germany has introduced the point of care rapid test at schools to get the kids back to school, where they'll be monitoring the virus in schools as well. And also in instances of limited diagnostic resources where molecular or PCR tests must be prioritized. So we do know that PCR testing is a gold standard, and it's also the availability of this assay is not largely available. So we can prioritize this by introducing the rapid, the antigen testing in this scenario as well. So the WHO and the CDC also has given guidelines for the antigen testing in comparison, I mean, with regard to the molecular testing. So if you have a symptomatic patient and the antigen test is positive, there is no PCR confirmatory test that needs to be done. For a symptomatic patient where the antigen test is negative, then you can consider doing a PCR confirmatory test. For asymptomatic patients where there's no known exposure to a COVID-19 a person, if the antigen is negative, then there's no PCR confirmatory test required. But if an asymptomatic patient had a close contact with a COVID-19 and the antigen is positive, then we can use a PCR test to confirm this. We can also use it to confirm infection where the PCR could be positive due to remnant RNA material that is left of the live virus. So in situations where the virus, the patient has the virus and the viral load in the patient is not a lot, so the patient is not infectious. So with the antigen test where we are testing for the nucleocapsid protein, which is the most abundant protein in the virus, where the viral load is high, the antigen test can be utilized in this scenario. So if you look at the workflow when using our rapid point of care antigen testing, It's very simple. You either use a nasopharyngeal swab or a nasal swab. You first add 10 drops of the sample extraction buffer into the tube. You need to keep the tube upright. We insert the swab into the tube, roll the swab around plus minus 6 times inside the tube. We squeeze it at the bottom of and the sides of the tube just to make sure the virus is sort of transferred into the tube, and let it rest for about a minute. Then we safely remove it, discard the swab, and then we insert the dropper tip into the tube with the specimen. Then we use the cartridge, we lay the cassette flat. We add 4 drops of the test sample into the sample well, and then our result is available in 15 minutes. And this is how the cassette looks, the reading area, our control line, our test line, and then our sample pad where we insert the sample. And then for a negative sample, our control, we will just have a line through our control line. And for a positive, we will have a line through the control line and the test line as well. So this is basically what is happening in the cartridge with regard to a negative sample and a positive sample. With a negative sample where there's no nuclear capsid protein available, the sample just runs through, and there's no binding of the proteins to the antibodies, except for the control line. And then for a positive sample, we have the nuclear capsid protein binding towards the monoclonal antibodies. If you look at our serology, high throughput serology antigen test, the workflow of this is pretty much simple as well. We can use both the nasopharyngeal and nasal swab. We collect it, we put the swab into the specimen, either a 1 or 3 ml of the recommended transport media, for example, the UTM or the VTM. We vortex it for about 10 seconds and then remove the swab. In order to inactivate the virus from the specimen, we add 2 drops of the lysis reagent into the 1 ml of sample, depending whether it's 1 ml, 3 ml, you would add 6 drops. We gently mix the sample, we incubate it for about 10 minutes at room temperature, and then we load it either onto a Telica IM analyzer or the Ocenta XPT analyzer, and it's ready for testing and for analysis. If you look at the different scenarios and the time frame at each scenario, if we are doing an on-site sample collection, we can collect, we can even aliquot it for a potential PCR confirmatory test. Then we add the inactivation, the lysis reagent to inactivate the virus, and then we can test it. If for the pop-up labs, and we're looking around less than 45 minutes for the whole process to run through. For the pop-up labs, you can collect the sample, inactivate the virus, and immediately load and test your sample, which is also less than 45 minutes. If we're looking at the high throughput, for remote collection, we can collect the sample, transport it, inactivate it at the lab before inserting it onto the instrument, we load it, and we test it. So pretty much the workflow is pretty much simple. And as I said, when we compare our assays, both the point of care antigen test and the high throughput lab-based antigen test, we have the lowest limit of detection, which gives us the highest sensitivity. And then this is the amount of virus required to infect a sample under laboratory conditions. And if we compare it to our competitors, you can see both our assays have the lowest limit of detection. If you look at our molecular testing, the sample types are the nasopharyngeal and the oropharyngeal. We have 100% sensitivity and specificity, and depending on the throughput, you can receive your result under 3 hours or under 7 hours. Our assay was also ranked in the top 5 for analytical sensitivity in an FDA comparative study as well. and it detects the major SARS-CoV-2 variants of concern at the rate of 100%. We target the two highly conserved regions within the virus, which is the ARF1AB and the NG, and it's also a single well dual target design, which allows for accurate SARS-CoV-2 detection. And once again, just to elaborate further, that we are doing dual targeting for the detection, where we are targeting the ARF1AB and the NG targets, which gives us 100% specificity and sensitivity, which gives us confidence in our results. We have also did cross-reactivity testing in vitro studies with 26 common human flora organisms and pathogenic organisms causing respiratory infections, and this was performed in triplicate using several pools of contrived samples spiked with commercial pathogen sources or extracted pathogen DNA/RNA, and there was no cross-reactivity observed for these tests. If you look at our workflow, it's pretty much simple as well. We collect the sample, we extract, we do the extraction, we set up the PCR on the plates, then the amplification and detection is done, and then the analysis and the interpretation. And if we're looking, if we're using our third-party instruments, you can have the different time frames for the different throughput of samples that you are analyzing. And this is another unique feature, is that we can mix and match different assays, different FTD assays on the same sample plate as well. We also have 21 IVD assays available, FTD respiratory assays available for the detection of the 20 viruses and 1 bacterium. We have the FTD flu and the HRSV assays, and then also soon to come is the combo kit with the FTD flu and the HRSV CoV-2 assay as well. If we go over to patient management and monitoring and focusing on the antibody testing, we have both the total assay and the IgG assay. With our IgG assay, we are unique in the market where our sample type also includes the finger stick as well, where we can use capillary blood. And with regard to sensitivity and specificity, we are all above the 95–96% mark. For our total assay, we are looking at 10 minutes for the time to first results with a throughput of 440 specimens on our Telica IM. And for the IgG assay or SCOP-G assay, 24 minutes with a throughput of up to 440 test power. One of the most unique features is our smart selection of the S1 RBD as a target to detect antibodies that block the virus into the cells. And this has been aligned with the development of vaccines. Our assay is quantitative, so it will give you a value, which will also help assess antibody levels and track the immune response over time. Our total assay was recognized by Public Health England as a top performing antibody assay where it met both the criteria for sensitivity and specificity when compared to other assays on the market as well. We were the first major company with an assay to detect neutralizing antibodies, and I will speak about that a bit later. We have done studies, and these studies are available in our IFUs for those assays. And most importantly, it helps confirm vaccine effectiveness and persistence and duration of the immune response. And these assays can be run on more than 9,000 of our analyzers that are installed worldwide. And if you look at our point of care antibody testing, also can be used in scenarios for remote testing, where core laboratory is not available, where there's phlebotomists and laboratory personnel that are not available, and where blood draws cannot be done at a large scale, and where the result is needed right away as well. It also has a very high sensitivity and specificity, and you can receive your results within 15 minutes. So despite the unprecedented advances in our understanding of COVID-19 and in providing the effective vaccines, some questions still remain. I mean, these include a better understanding of the immune correlates of protection in infected, reinfected, vaccinated individuals and donor convalescent plasma, which we require the length of time in which immunity persists. So there were various studies done and reported, including vaccine studies, where antibody levels were used to determine using the various assays, and they have their various cutoffs. Now, this limits the ability of researchers to correlate these assays when doing comparisons. So standardization is of the assays is a way to allow comparisons of the results across the different assays. And this can be accomplished with a reference material that is well characterized. So recently, the United States CDC highlighted the need for a standardized SARS-CoV-2 quantitative IgG and neutralization assays. So the EURM07 is the reference material that was made available for this standardization. And how did we approach to implement standardization? By proving the efficacy of our serology assays. So we selected the right target, which is the S1 RBD, which I'll be covering a bit later as well. We demonstrated that our target picks up neutralizing antibodies. We have done both testings with the plaque reduction neutralization test and also the pseudovirus neutralization test. Sorry. I have 1 minute left. Oh, okay. And then we've developed standards across many major manufacturers by partnering with the CDC and the JRC to determine the comparable levels of neutralizing antibodies across the different manufacturers. And then also we are partnering with the CDC and the Joint Research Council of the European Commission to collaborate with sites that have vaccinated samples and with clinical data and severity of disease. So since I have only 1 minute left, I'm just going to speak about the virus. As you can see, we have different proteins of the virus, and then antibodies bind to all these parts. But the question we need to ask ourselves is, are those antibodies neutralizing, and do those antibodies prevent infection? Now, the S1 RBD is part of the spike protein, and this is the part that connects to the host cell, which is the ACE2 receptor. So the antibodies that prevent this connection are the neutralizing antibodies, and this is what our assay is measuring, neutralizing antibodies, and we give a quantification for this. And as you can see that most of the vaccines target the spike protein, like your AstraZeneca, your Pfizer, and your Sinopharm. These were the tests that we've done, the plaque reduction neutralization test and the pseudovirus neutralization test, to prove that our assay picks up neutralizing antibodies. This is also a document that we've published in collaboration with the IFCC to show that our assay is detecting neutralizing antibodies, and we can associate a value, an index value to it. This is also, we've also standardized ourselves. The WHO also released a standardization sample, which we participated in and got an index value to there as well. And this is the different collaborations we've done with different institutions, the CDC, the JRC, where we have published documents that states that our assay is detecting neutralizing antibodies with a quantifying value to it. We've also, with this reference material, standardized that with different manufacturers that has using different proteins, target proteins, they can use this as a reference value to associate neutralization activities for the assay. And then finally, the most important thing, we would measure. So we've also got a document available where we can identify when the antibody assays can be utilized through the vaccination process. Thank you. I'm done. Sorry about that.
Nice, very, I think that it's much time.
Yeah, there's a lot of information. There's a lot of documented information.
Just one question. Yes. When you make this study, you compare the test
Yes, for our high throughput serology assay, we compared it to our FTD PCR test. Remember, it's ranked in the top 5. So we did the comparison with that, and we have the detailed information regarding that comparison.
The second issue, I noticed that in antigen test, they become sticky frozen after 2 minutes.
Yes. Yes.
And if you check the antigen test for newly diagnosed patient, the result is not marvelous. But if you follow up the patient after 2 days, the patient will check positive or negative, and the result is reliable under my experience.
Yeah, so as I've explained with a one slide, you've got a time frame where your viral load is at its maximum when the virus is at its maximum, which is for your antigen test, 1 to 3 days pre-symptom onset and up to 10 days post-symptom onset. So that is a time frame where the viral load is at its maximum, and that's the best time to utilize antigen testing. I would recommend to use it as, because PCR test takes a lot of time. So for symptomatic patients as well, that's posting symptoms, I would recommend using the antigen testing first. And then if you have any conflict with the results, then you can confirm it with the PCR test. Because it's faster, and also it has a high sensitivity and specificity. So if a patient comes into an ER with symptoms of COVID-19, sorry. We can discuss this at a later stage. I'm available, and yeah. Thank you for your time. Thank you, everybody.